So what we'll be talking about is actually we have to talk about atrial fibrillation, which is chronic before surgery, and then we move to actually the post-operative atrial fibrillation, because the treatment, as you will see, is very similar. The risk factors are similar, and actually later on the prognosis is similar. So we start with atrial fibrillation before surgery. It is definitely the most common sustained cardiac arrhythmia, and no wonder that you will encounter a lot of patients having atrial fibrillation before surgery. And then atrial fibrillation with an acute onset after surgery will be called new onset perioperative atrial fibrillation, and we'll use this shortcut POAF during this presentation. What is important is that actually thromboembolic events risk, heart failure and death are very similar between these two entities. So either you have a atrial fibrillation outside operating room, or it's a new onset atrial fibrillation after surgery. The long-term risk and short-term risk of it, it's very, very similar. So these are two large studies from North America, and actually about 38,000 of patients undergoing non-cardiac surgery of higher risk, and they actually registered about 11% of patients having atrial fibrillation chronically undergoing surgery. In a study that we performed in patients above 45 years of age in non-cardiac surgery, this was 5.4% of chronic atrial fibrillation with ECG changes of atrial fibrillation on admission, vision study. So it's a common condition. And of course, these patients will have increased 30-day mortality, cardiovascular diseases, and stroke after surgery. And just to put it in context, when you have a patient undergoing surgery with atrial fibrillation, his risk of dying after 30 days is 2 times higher than a patient with coronary artery disease. This would be 6.4 versus 2.9%, so 70 increase in relative risk. So what we have to focus on dealing with patients with atrial fibrillation. Definitely, we should actually focus on two things. One is ensure hemodynamic stability, and the other is preventing thromboembolism. And we will do it with optimizing cardiac treatment, treating underlying conditions if any are new or known, or we should look for them if we suspect some. And a good example would be thyrotoxicosis. But for sure, in all patients, what we have to do, we have to think of managed rate and rhythm and anticoagulation therapy. So in terms of rhythm control, in the last few years, it has become much more common to actually try to reverse the atrial fibrillation and regain the sinus rhythm. So we'll have a lot of patients coming after ablation or using antiarrhythmic medications, and if it's like a sinus rhythm, that is perfect. We just continue with antiarrhythmic drugs during the time of the surgery. However, you have a lot of asymptomatic recurrences of atrial fibrillation that can be detected before surgery. If the surgery is urgent, of course, we continue trying to control the rate. If we have time, we may think of reversing it again, knowing that we'll have to implement anticoagulation treatment. So if we have to do the surgery, then it's definitely worth to control the rate of the patient. And controlling the rate of the atrial fibrillation, this is in purpose to actually prevent ventricular arrhythmias and cardiac ischemia during and after surgery. Probably reverting the rhythm is not a good option because of the anticoagulants. So if we go for rhythm rate control, acceptable rate would be between 50 and 100 beats per minute, and acceptable rate after surgery would be about 120. These are not large studies suggesting it, but knowing our practice and according to this New England Journal publication, these are quite good rhythm control during surgery and afterwards. In terms of anticoagulation before surgery, it's of course establishing thromboembolic and bleeding risk. We're discussing a second bridging, which become less frequent in the recent years. But we definitely have to be careful in patients that have a special risk of bleeding or are on a double antiplatelet therapy, undergo neuraxia, anesthesia, or at least it's planned, or have a surgery in a place that potential bleeding would be devastating, as brain surgery or eye surgery. We have to remember that some procedures actually do not need stopping anticoagulation drugs, and this would be cardiac pacemaker implementation or some other small procedures. And the general trends and rules are actually that if only this is not a very high-risk patients of thromboembolic events, we should aim for stopping the medications to ensure no bleeding afterwards. So cessation of vitamin K antagonists when only possible 3 to 5 days before surgery, and diet oral anticoagulants 3 days prior to surgery, of course, depending on clinical status, kidney clearance, and all things all of us know. So this is CHATS-2 score. The most recent is CHAT-VAS score. I'm showing the older one because the studies I will be discussing in a second are based on this score. So this is predicting thromboembolic risk in atrial fibrillation. And we have 4 diseases here: congestive heart failure, hypertension, diabetes mellitus, and stroke or TIA. And we have age above 75. It's called CHATS-2 because stroke and TIA are counted as 2 points. So according to 2 large trials, and this was BRIDGE trial and PERIOP-2 trial, actually anticoagulation bridging, so stopping anticoagulation and giving heparin before surgery should not be performed, should not be bridged. This patient should not be bridged if they have CHATS score 3 or less, because you will probably then have more bleeding than reduce the thromboembolic events. We are not certain about patients with CHATS score 4 or above, and this is a group that you have to consider individually. And what you should do is consider bridging when only there was a recent thromboembolic or systematic stroke, recent cardioversion, or in echo you have signs of atrial thrombus. We should definitely avoid bridging if there was a recent, and recent I mean 3 months bleeding, especially intracranial. So we move to the surgery and post-surgical complications. So you may encounter patients that did not have atrial fibrillation, but develop them intraoperatively. And then the first thing that we have to establish is the patient in a stable condition? If he or she is not, and by this probably you will have symptoms of hypotension, pulmonary congestion, ECG signs of ischemia, we should aim for cardioversion during the surgery, if only possible. If it's not possible, or it would be probably compromise the surgical procedure, or it's otherwise not doable, we should aim for rate control. And the control of the rate would be about to get a rhythm of 100 to 110 beats per minute. To do it, we usually use beta blockers or non-dehydropyridine calcium channel blockers. And as for examples, I would probably use esmolol or metoprolol in boluses, or maybe diltiazem. And with this, we move to postoperative atrial fibrillation POAF and this new onset atrial fibrillation. So in most studies, this definition means that this patient did not have atrial fibrillation before surgery and developed it just after or during surgery. The incidence of POAF varies a lot between studies. It depends on the methodology of the studies, was it retrospective, registry-based, prospective studies, but the incidence is in the round of about 1% to 8%. What we can say for sure, it's like less common in minor surgeries, and if we take it as a baseline, it would be 3 times more common in major non-thoracic surgery, and most common finding in thoracic surgery, almost 4.7 times more common than in minor surgery. So definitely you should expect this complication if you're doing thoracic surgery, and you might find it as well in major surgeries. Important thing is, as we already mentioned, that actually the risk of developing devastating complications is very similar in these patients with POAF when compared to patients having atrial fibrillation outside operating room. So the incidence of stroke and death both at 30 days and 1 year is increased. And for stroke, this would be between 37 to 62% more events, and for actually chances of death would increase by about 40%. We get back to the risk factors for developing POAF, and this is a large study we presented 2 years ago from the VISION data. And besides major surgery and thoracic surgery, the risk factors would be having underlying conditions as hypertension, diabetes mellitus, coronary artery disease, or COPD. And definitely it becomes more frequent within the older population. What we found also was that patients with increased levels of anti-proBNP markers had more frequently atrial fibrillation after surgery POAFs. These were the risk factors, and this is just to let you know, recently, a month ago, a large study on preventing POAF was ended. This was a study in more than 3,000 patients, multinational and major thoracic surgery, and they were trying to prevent POAFs with anti-inflammatory treatment, and it was colchicine. And actually, the results are negative. No effect on preventing POAF. The only effect they got was diarrhea, so probably not the best thing in preventing POAF. So last few slides, this is how we manage new onset atrial fibrillation after surgery. And already discussing atrial fibrillation treatment before, we should have in mind that this will be very similar. But how do we do it in practice? And these are results that we gathered from several large studies. And first are the VISION data. So in patients that develop atrial fibrillation after surgery, POAF, only 21% received anticoagulation therapy in hospital, and only 2.7 had anticoagulation therapy on the discharge note. So not many. This was a study ended up 5 years ago. So if we think that practice may change, we checked as well this data on POISE studies, 1 to 3. This is a period of almost 20 years. A POISE 3 study ended up recently. So a group of 27,000 patients, an incidence of POAF about 2%. So what we found was that actually rhythm control drugs were used in almost 50% of the patients with POAF. However, anticoagulation was still not used often and was between 16 and 33%. So we definitely tend not to treat the patients with POAF, and according to the definition, according to the guidelines by cardiologists, we should actually treat this complications very similarly to the atrial fibrillation outside operating room. The difference, main difference for me, is that we should look for reversible factors. So there may be factors as electrolyte, fluid abnormalities, bleeding, pain, infection, or acidosis that we should treat, and perhaps atrial fibrillation will move away. So more than 50% of POAFs actually will resolve to sinus rhythm within 24 hours on their own. So if it doesn't during this 24 hours, the guidelines say it's worth to actually go for cardioversion, either with electric shock or with medications. However, we always have to think of that this is a patient just after surgery, so perhaps he or she still has increased bleeding. We definitely use rate-controlled medication as mentioned before. And what we have to have in mind is that the long-term cardiovascular risk is very similar to atrial fibrillation outside the operating room. So actually, the treatment probably should be similar. However, whenever we discuss this problem with people working in operating rooms and doing perioperative care, it is not consistent among the specialists, actually, should we treat the patient for a longer time with anticoagulants. There's no data convincing data on patients just after surgery having atrial fibrillation. So definitely this anticoagulation length of treatment still needs larger trials. So to sum up, in treatment of atrial fibrillation, you should always consider other coexisting conditions. Think of rhythm control and rate control, and finally on anticoagulation. Despite growing evidence of short and long-term outcomes of POAF, most patients do not get anticoagulation treatment, both in hospital and at discharge. So there's an urgent need for randomized trial in POAF anticoagulation treatment. Thank you very much.
Thank you very much, Professor Szczeklik. Do we have any questions from the audience? Very interesting and common problem. So I have one question. From your data for the patients that did not go home with anticoagulation, which was large numbers, do you have any knowledge from those studies of those patients who just had a short-term episode in the hospital that resolved with electrolyte and fluid treatment as opposed to more chronic?
Yes, the data from, it's not our data, but the data from retrospective studies and registry studies say that the patients that actually did not receive anticoagulation treatment in hospital and at discharge had worse prognosis than those that received this treatment. But this you have to treat, you have to keep in mind, it's like methodologically it's not perfect. So I know several groups are actually thinking of starting or already starting studies on anticoagulation in peri-op period, and we're very much waiting for this as we are not sure actually. As I mentioned, it's like it very often resolves itself within 24 hours. So should we actually keep the patient on anticoagulation for a longer time? I can't say without the studies.
So we await further investigation.
Even if the patient doesn't receive anticoagulation because the atrial fibrillation has been auto-limited, for example, do you think that this patient should be assessed by cardiovascular problems or any other things after the end of the postoperative period?
Yeah, for sure. It's like if it's like a prolonged atrial fibrillation, I would definitely go, even if it gets back to the sinus rhythm, to a faster, approach by a cardiologist or cardiologist seeing these patients after discharge from hospital, maybe thinking of like some longer ECG monitoring afterwards. So definitely this may occur again. So it's worth considering. Yeah.
We have one question from the audience.
Hello, Elizabeth Wilson, Edinburgh. Can I ask how much the advice varies with post-operative surgical patients who go on to remain critically ill for a prolonged period of time, in particular the management of the arrhythmia, where the trigger may not have been solely the surgery, but the ongoing critical illness factors?
Yes, so if I understand well, it's like your question is that you do not have like reversible factors. It's critical care and after surgery, yes, and you have atrial fibrillation.
That there may be sepsis that's promoting the arrhythmia rather than purely the surgery itself, like say pancreatitis, ongoing infection, where the arrhythmia is likely to be related to a critical illness component, not just the surgical component, and the decision around anti-arrhythmia therapy and defibrillation.
So of course there are several things you consider before this, before this decision, or should we try to get the sinus rhythm again? And I would say one of this main factors to consider is how long the atrial fibrillation already lasts. So if it lasts for more than 48 hours, then you have to go with anticoagulation, and you have to remember it about after surgery. And definitely this will be also like looking at the heart, at the chambers, how big they are. You may do 1 or 2 trials to get the rhythm again. But in the recent years, definitely there's much more like impact on trying to regain the sinus rhythm than we had before. Yeah.
Okay, thank you very much for your